I thank IMA and the organizers for giving me this opportunity. We all know that total joint replacements are probably the biggest success stories as far as the history of surgery is concerned. Normally, I'm a joint replacement surgeon. I was asked to talk about joint replacements, and I thought, these days, one of the problems when surgeries become very successful is that it becomes done for appropriate and inappropriate reasons. And surgeons who are probably not very well trained do it. Surgeons, they're being done in all hospitals. And one of the problems of that is that we see a lot of complications from joint replacements, which should be one of the biggest success stories. So I thought we will look at various ways of avoiding a surgery whenever possible. We'll look at 3 different case scenarios. I've got, these are 3 patients who've been referred to me for surgery. This lady is a 45-year-old gynecologist. She has slightly high BMI, and she has got pain when she stands for prolonged periods during surgery. She has been referred, she has some, if you see here, there is some medial joint narrowing. She has been clinically diagnosed to have a medial meniscal tear, and she has been referred to me for an arthroscopy. This patient is an IT professional. He is 50, fairly active, but he's got pain mostly on walking. As is common with IT professionals, he has come to me with this MRI scan, which he has self-prescribed, which shows a medial meniscal tear. And again, it's a degenerate medial meniscal tear. This has been referred for an arthroscopy. The last lady is probably the fittest of the lot. She is 85 though. Very active. She lives in a 10-acre estate with her 5 dogs, and she has had pain in her right knee, which is probably referred from this hip for the past 6 months, and she has been off her legs for the past 2 weeks. So these 3 patients have been referred for surgery. We will look at what are the conventional ways of treating to avoid these surgeries, and what are the not so conventional ways. Osteoarthritis, as we all know, it's becoming an epidemic to the proportion that Time magazine brought out this cover story. We know that our population is getting increasingly old, population is getting increasingly obese. So these 2 are the drivers for osteoarthritis. So if you look at which joints are affected, you can see that the cervical spondylosis and lumbar spondylosis, we all know they are fairly common. The next commonly affected joint in India is, at least in our country, is the knee joints. The knee joints, most of them present with either varus or valgus deformities. It's very, very common to get knee joint arthritis. Surprisingly, another joint which is commonly affected is the carpometacarpal joint of the thumb, which presents with pain around the base of the thumb. The problems with these, arthritic conditions is that they are painful, and they, especially in the elderly, they negatively influence the lifestyle. They cannot walk as much as they want, and they end up in, at least some of them end up in depression. And another problem that as orthopedic surgeons we see on a regular basis is that when they have, let's say, for example, arthritis in the knee, their knees tend to give way as they walk, and this causes falls and thereby fractures like hip and distal radius. As far as diagnosis is concerned, the history itself is enough to diagnose osteoarthritis. Most of them have what I call as a starting trouble. They get pain as they start to walk, and as they walk through, the pain improves. All you need is X-rays to diagnose them. Most of the time, you do not need any sophisticated investigation. As I started training, these were 2 basic tenets I was told about arthritis, that there is no proven treatment to prevent it. There is no proven treatment to reverse it. But we'll look at if it is completely true. When we know that there is nothing to reverse or prevent it, our aims are to educate the patient probably. That is probably the most important. And if you educate the patient properly, most of the time the pain improves, and thereby it improves the function. We will also look at ways of altering the disease process and its consequences. So if you look at the traditional ways of treating it, you can, if it's mild symptoms, you start off with exercises and physical therapy. Weight loss, you can try orthotics. If the symptoms become moderate, you try with analgesics and low-dose non-steroidals. As they go up, you go to stronger analgesics, and towards the top, you do surgeries for them. Overall, to reduce to reassure the patients, I feel that probably patient education and lifestyle modification is probably the most important. And the patients that come to me, 70% of them improve just with reassurance that this is a normal aging process. And if you modify your activities, if you reduce your BMI, the symptoms will improve. Physiotherapy is an extremely useful adjunct. Patients often ask what sort of exercises should they be doing. I think the answer is they should be doing low-impact aerobic fitness exercises. So if they want to go on a treadmill, it's fine, but they should not be running. They can walk on that. Cycling is an extremely good exercise. That is, it doesn't involve impact as such. So is swimming. So these are very good exercises, and low-impact exercises improve the function and pain significantly. Braces, I do use them occasionally. Some patients find them useful, but the problem with braces, especially the big ones, is that they are cumbersome. So the patient compliance is often not so great. So these sort of big braces are most of the time used by patients once or twice, and they discard it. In contrast to this, simple small kneecaps, which are made of clothes and all that, are pretty useful, and patients find it much more easier to use. As far as pain relievers are concerned, presently paracetamol is the drug of choice. You can give it up to 3 grams per day during acute exacerbations. Non-steroidals, as we all know, have its side effects, including gastrointestinal problems and renal dysfunctions and all that. So we tend not to use it as far as possible. Recently, over the past few months, we have got buprenorphine and fentanyl patches available in the city. These are some of the very useful medications as far as the elderly are concerned, because the incidence of side effects is pretty low. You can attach it, patient compliance is very high. You can use it during periods of exacerbation. You get it in, if it's buprenorphine, you get it in 5, 10, and 20 milligram patches. It's around 300, 400 rupees. You can use it for over, the same patch can be used over a week, and quite a few patients find it very useful. I get asked about glucosamine and chondroitin sulfate. This is a huge industry, as you can see here, almost $1 billion industry. Unfortunately, these are absolutely useless in osteoarthritis as far as studies are concerned. Some patients find that pain improves, but so does placebo improve the pain. So I think it's mostly a placebo effect, but it's generally not recommended these days. Steroid injections are again useful for osteoarthritis for improving the acute exacerbations, but otherwise it does not have any role in the long-term pain relief. Over the past 10-15 years, viscosupplementation, something called as hyaluronic acid, has become very, very popular. This is this is essentially, it comes in a small syringe, and it's like a gel. It's like just like your normal joint fluid. It's thought to improve the viscosity and lubrication, and it is thought to be counterproductive. But thoughts are one thing. Unfortunately, the truth is a different thing. There are a number of products which have been approved by the FDA. These are injected over a period of 1 to 5 weeks, and you have to repeat these injections every year. Some patients do find it useful, but like I said, it's mostly a placebo effect, and the verdict presently is that this should not be recommended for osteoarthritis as a modality for improving pain. So that comes to what can we do differently to improve the pain and also to improve the degeneration that is happening there. If you look at the etiopathogenesis, the main problem is that once the cartilage becomes dysfunctional, the interleukin-1 levels go up. So these interleukin-1s are the ones which cause the cell destruction and start the cycle, causing the COX, the COX enzymes and all that, and thereby producing pains. One of the recent advances that has come out recently is what are called as the platelet-rich plasma injections. So platelet-rich plasma is essentially blood that is centrifuged. So when you centrifuge blood, we all know that you've got the serum there, you've got the platelet layer that comes in between, and the RBC layer that comes out at the bottom. So all we do is we centrifuge the blood, take out this middle platelet layer, and you can, the platelet layer has got a lot of growth factors in the platelets, and these are thought to enhance the tissue repair and healing, and definitely improves the pain because of that. And normally we take out around 2 to 3 millimeters of this platelet layer, and you inject it into the painful area. It's an extremely useful adjunct for things like Achilles tendonitis, where you don't want to inject steroids because of the risk of rupture. It's very useful for tennis elbow, so much so that many surgeries for tennis elbow we have avoided because of this. It's also used for whenever we do a meniscal repair, we use it as an adjunct to make the meniscus heal. Another fascinating treatment that has come out recently over the past few years is something called as autologous conditioned serum. It's also known as orthokine. This is Kobe Bryant. He was one of the basketball players. Some of you may recognize him. He is from the Lakers team. He is one of the topmost players in the States. And he developed knee arthritis. And when he developed arthritis, he traveled all the way to Germany, because in America this treatment is not recognized by the FDA yet. So he went out all the way to Germany in 2013 and came back to playing national level basketball again. He actually popularized this technique, and a number of similar users have been, top athletes have found it extremely useful. Here what we do differently is that we take out blood. It is incubated along with glass beads, and when you incubate blood along with glass beads, the white blood cells secrete this interleukin-1 receptor antagonist. And as we heard from the pathogenesis of osteoarthritis, we know that interleukin-1 cytokines are the drivers for the pain and the tissue destruction. So you centrifuge this blood and you take out the topmost layer. So you take out the topmost layer here, and that has got the autologous serum along with activated white blood cells. And you take it out into 4 different syringes. It's 2 ml each. And this is also just like PRP done as an office, in an outpatient procedure. And you inject it at weekly intervals into the joints. And many studies have shown that the pain improves significantly. And I'm glad to report that this is available in our hospital now, and we have found it extremely useful, at least for the short, 1 to 2 year period. Is there any evidence to use it? There are several case series, but there are absolutely no randomized control looking at it. So we have no class 1, level 1 evidence that this improves the symptoms. It is used in mild to moderate osteoarthritis. These are expensive treatments. It's around 30 to 40,000 rupees for these injections. So coming to surgical treatment, when do you opt for a replacement? You should, these days, like I said, the surgery is being done even for very small amount of pain. Generally, when you do it for, when the symptoms are very mild, is that the patient's satisfaction rates go down, because the pain gradient improvement is very low if you do it for a mild pain. So you should do it only when the patients have significant symptoms. But these days, the techniques have improved so much, we can correct almost any deformity with this, whether it's severe varus, valgus, or a combination of these. You can correct most of these deformities, and joint replacements do last a very long time with the present technology. Going back to our 3 patients, this doctor who has symptoms only after prolonged, when she stands in theater for a long time, all she needed is a bit of reassurance. We got her on a weight reduction program. She started exercising regularly and her symptoms improved. She didn't require surgery. This patient who was referred to me with a meniscal tear, degenerative meniscal tear, this one, if it was around 5 years ago, I would have gone and done an arthroscopy. I would have excised this torn meniscus. This is what I would have done around 5 years ago. Recently, there have been a number of studies which actually look at whether is there any point in doing arthroscopy for these degenerative meniscal tears. This is actually a fascinating study from NEJM. NEJM normally doesn't publish many orthopedic papers. In NEJM, they looked at partial meniscectomy versus sham surgery. So what they did was, all the patients with degenerative tear, they divided into 2 groups. One group, they did a proper arthroscopy, excised the tear. Second group, all they did was 2 scars around both sides of the knee where the arthroscopy would be. And they looked at the results, and they found that by 6 months, both the groups' pain improved. There was no need for surgery. Even without surgery, without a arthroscopy, the patient's pain improved. So with this evidence, this present-day treatment for this degenerative meniscal tear is just exercise, nothing more. But this elderly lady who has got severe pain in her hip, she is the one who would benefit from a replacement. Her mobility is very limited. The moment we do her replacement, she is mobile again. The next day her pain is gone and she is back to her normal routine. So what is in store for future? Over the 5-10 years, I feel there is a major development happening in the area of stem cell research. I think there will be a lot of commercial interest in this as well, so we need to take it with a pinch of salt. I hope that in time it will be extremely useful for the patients, and we may not need to do surgeries anymore in future. Thank you very much.
You're talking about the injections to the knee. print, on an average, how many times you have to inject? So one-time process?
This orthokine injection is generally a one-time process. You inject it over, over a period of 4 weeks. If the patient's symptoms recur after a period of time, you can inject it again. But generally, my experience is it's an expensive treatment. If it doesn't work one time, there is no point in injecting further.